Hello and welcome to Patient World. Today we have our special guest, James O'Hara. Welcome to the show.
Hi, Dr. Hexter. Thank you so much for having me. I'm excited to be here.
Let's get started by having you tell the audience about yourself.
Yeah, so my name is James O'Hara, and I am a nurse practitioner. I have a big passion for preventive medicine, which I'm sure we'll get into, public health and those sorts of things. I guess going back to the very beginning, the way I got into medicine was actually on the patient side of things. When I was in 8th grade, I broke a bone, actually two bones, my radius and my ulna, and developed a complication known as compartment syndrome. So this was a pretty profound experience for myself and for the audience. Those who don't know about compartment syndrome, this is a condition where there is such a large amount of swelling that the perfusion to the tissue can be compromised and can have excess pressure on a nerve that causes some lasting damage. In my case, I was very fortunate, had a good mother that got me to the hospital and a good surgeon that performed an emergency surgery, and I did not have any complications. So that's kind of the start of how I got into medicine. And then there's been quite a journey since then that's got me to where I'm at today.
So tell us about your interest in preventive medicine.
Yeah, so my interest in preventive medicine came a little bit later. This was when I had been working in primarily on a cardiology unit as an RN, registered nurse in the hospital at that time. And I had seen all these things, these patients coming in with, heart attacks and strokes, people having open heart surgeries, which are, really fantastic procedures as far as how far the technology has came and what we're able to do. But in doing some research and reading and talking with the cardiologist, I understood that about 80 to 90% of these things are preventable. Sometimes there are genetic predispositions where, people have these things happen and it's not fully understood why. But for the vast majority of people, these were things that could have been prevented with, lifestyle interventions, medications, different things that they could have been screened for earlier in life to pick up on, so that they don't have to go through these experiences and have decreases in their quality of life and their overall health later on.
So what preventive issues do you feel most strongly about?
So I'm very passionate about preventive cardiology. There's sort of a checklist that we go down, and we want to make sure that people are in as many low-risk categories as possible. But on a broader level, I think there are foundations of health that almost everybody can apply. A really interesting Harvard paper out of, I think about 2018, it came out, looked at 5 behaviors that people are able to use. And on average, those people are going to live about a decade longer, a little bit more for women, a little bit less for men. But those behaviors are regular exercise, maintaining a healthy weight, avoiding smoking, avoiding excess alcohol, and having a healthy diet. So those are 5 things, and probably the, diet, weight, and exercise, those things all kind of plug in. And if those are all in check, they're going to balance each other out. It'd be hard to have diet, exercise, and then have body weight that is not where it should be. But those are the foundations that I think that everyone can apply. And there's, a lot of individualization there. So, what type of diet is healthful that someone also enjoys? What type of exercise do people enjoy? Because you can write up a perfect plan for someone, but if it's not something that they can stick to, if it's not something that they enjoy, it's not going to be particularly useful. A healthy weight, a BMI is a good start, but it doesn't tell the whole story. I think that this gets a bit more credit than it should. BMI is getting more weight than it should when people go to their doctor's office. Now, if somebody has a BMI of something like 50, more than likely that person is not at a healthy body weight. But really what I'm looking at is sort of the metabolic health of somebody. And really the biggest piece there is insulin sensitivity. So a lot of people will get a fasting glucose on their CMP when they go to their annual physical. That's a blood test that looks at your kidney function, liver function, electrolytes, and your fasting glucose is on there as well. But this isn't the first step in screening for insulin resistance in our practice. It's a pretty good test if you're going to pick up someone who is actually diabetic. But there are people who will go in and they'll take these tests. They've been fasting for 12 hours. And if you actually checked a hemoglobin A1C or a fasting insulin, you might see a very different story, even if the fasting glucose is normal. So for example, I think this is probably the case with my grandfather, who we think was diabetic for quite some time before it was actually picked up and the fasting glucose has started to run away. And I'm sure that's the case for some others out there, but seeing the hemoglobin A1C tells you a little bit more about the long-term picture of someone's average glucose. It's tied to the red blood cell over about 3 or 4 months. And then a fasting insulin, you'll often see elevated, 5 to 10 years before someone has elevated glucose. It's sort of the pancreas working overtime to control blood sugars. And we know that when people do become diabetic, that they've lost about 50% plus or minus of their pancreatic function.
So if a person is interested in the BMI, they can just pretty much Google it and find a calculator so they can plug in the numbers and they can get their BMI. So that's something that the audience can use to get some specific information about that. So let's talk a little bit about alcohol. Something that I found so many times was I would ask the patient, do you drink alcohol? No, I don't drink alcohol. I'm just drinking 6 beers a day. Like, well, that's alcohol. So can we talk a little bit about what you consider to be excessive alcohol?
Yeah, that's a great point. The history taking is very important because being clear about our definitions and even the medical terms that we use when we're talking with patients, we're going to make sure that we're communicating with them in a way that they understand. So, in your case, the patient was thinking of hard liquor as opposed to something like a beer. Excessive alcohol, I think the data is still mixed there. I know that for a while there was thought to be some benefit to maybe 1 or 2 drinks per day, depending on if someone's male or female. And then it looked like some UK data showed that there's a negative impact on brain health, regardless of the amount. And then there was another study that looked like, well, we do see people that are, low level alcohol users, 1 drink per day, having decreased inflammation and so forth. So probably the healthiest amount is 0. And I think that the benefits that we see there on sort of the fringe studies are from the social connections that people have. Alcohol is kind of integrated into our social health, as it were. But really anything beyond, 1 drink per day or 7 drinks per week for women, and anything beyond, 2 drinks per day or 14 drinks per week for men is what I would consider more than likely detrimental to someone's health. I'm sorry, I heard secondhand smoke. What was the full question?
We talked about cigarette smoking, but what about secondhand smoke? You don't smoke, but your spouse smokes, but you.
Yeah, and secondhand smoke is still an issue. It's much less so than it was, let's say, 20, 30 years ago. But we know that looking at some of the longitudinal data with even secondhand smoke, so children that are exposed to this, they develop, they have a higher incidence of getting things like an asthma or other diseases of atopy like eczema. So there's some immune dysregulation that seems to be seeded there just from that exposure. So it falls into that bucket of the sort of public health concern. So this was something where I think a lot of damage was done with the sort of, I guess, the very slow process of unwinding, people's, understanding about just how harmful cigarette smoking was and the pro-cancerous effects of chewing tobacco, smoking cigarettes, the effects on heart disease. For a while, I know there's a museum up in Chicago that I've been to, a museum of medical sciences, and cigarettes were at one time recommended for asthmatic relief, as crazy as that sounds. So secondhand smoke can be a problem. As far as the way to unwind that, it seems like a lot of public education and a lot of time is needed to really get the public to grasp and really get the health authorities to understand, kind of what is going on there. And then there's a degree of, sort of personal responsibility as well. You certainly don't want to be, if you are a smoker and that's something someone's struggling with, you certainly don't want to be exposing your, friends and family to that sort of thing.
So tell me some of the public health challenges you see.
Yeah, as far as public health challenges, as of now, probably the 2 biggest things there are obesity and then the increase in mental health diagnoses that we've seen. So I suppose you could look at the mental health side of things in a positive light, saying that more people are now seeking out help for mental health issues because it doesn't carry the same stigma that it used to. So I think more people are being helped, and I think that's a good thing. But as far as those two increasing in incidence, I think this stems back to the environment that people are in. So if you look at, perhaps from an evolutionary standpoint, in our modern world, we really don't have any innate signals of safety in the environment. So if you look at historically, we spent lots of time outside. We had a very in sync circadian rhythm. We had not as many chronic stressors and concurrent stressors as we do in today's world. So people are running in more of a a fight or flight mode, as opposed to a balance between that sympathetic and parasympathetic nervous system. So I think that is a big part of what's going on with our mental health. People's sleep quality is not great. People sleep with TV on, with lights in the room, night lights, and that is going to, in general, decrease people's resilience to stress whenever they are kind of being exposed to all these small little stressors that we know are not good for our health. And something as simple as taking a nature walk, spending an hour in nature in the sunshine, that's shown to decrease the reactivity, specific brain region called the amygdala, which is sort of this center that determines whether your body is going to respond to a stressor or a stimulus or not. So there are ways to push back against that. Good sleep hygiene, spending time outside, trying to have routine, ways to mitigate stress. For some people, that is exercise. For some people, it's yoga. Something that I had written off for a long time was breath work, but in doing this, myself and hearing other people talk about it, it's interesting to see you can sit there and just by altering your pattern of breathing intentionally, you can bring down your resting heart rate 5 to 10 beats per minute, which is not uncommon, and that's fairly significant.
So can we talk a little bit about that? What exactly would people do as far as their breathing? What would you recommend that they do to bring down their heart rate?
So there's a couple of ways to go about this. One of the ways is something that was adopted in different military programs for a while. It's called square breathing, where typically someone has an inhale of 3 to 5 seconds. They hold their breath for 3 to 5 seconds. They breathe out for 3 to 5 seconds, hold for 3 to 5 seconds. And this is something that I've had patients do, and they find it helps with unwinding, sort of just focusing on only that breathing, especially when they're trying to settle down, go to sleep for the night. For people that tend to have ruminations or a hard time, I'm not thinking about things from the day whenever they're trying to settle down and wind down for the night. There's other things like a double inhale, where you're giving your body extra oxygen, because a lot of us do have some degree of hypoventilation that occurs if we are just being sedentary, looking at a screen. A lot of us are working desk jobs in the modern world. So doing a double inhale every once in a while to get plenty of oxygen into the system, flush out some of that carbon dioxide. That can be another useful breath technique. And then breath work is incorporated into a lot of different meditation practices, like yoga, for example. There's often group classes where the instructor is telling people specific times to breathe in and breathe out and release tension and stress and those sorts of things. So there's not one set way that's going to work for everybody. There are some people that don't find breathwork beneficial, but I think it's worth a trial because it's essentially a zero cost intervention, and it can be very powerful for some people.
No concerning side effects.
Absolutely.
So let's move to the blood test. What sorts of blood tests do you think people should be getting that may not be getting routinely?
Yeah, so this is a good question. And there's a lot of tests that people do get that I think are, appropriate. The traditional medical system does catch, some things with the blood tests that they do routinely, and the physical exam and the history. Those are very important. But looking a little bit closer, given that about 70% of the population is overweight, we would probably pick up on prediabetes earlier if, in addition to that fasting glucose, people were getting an A1C. Or even better than that would be getting a fasting insulin along with that marker, so that you could see these things much earlier. And then that can be the sort of wake up call that people need to make these changes. And in some cases, people see that and they can do a 180 and they can move back from their pre-diabetic state to a metabolically healthy state. And there's different thresholds for what people's metabolic health and how much their pancreas can handle before they progress. So that's one example. Other things that I think would be useful, some genetic screening for heart disease. There's a test called lipoprotein little a. This is a subtype of LDL protein, which carries cholesterol and can be deposited in the artery wall. And about 1 in 5 people will have an elevated number here. And as of right now, it's genetic. There's some trials going on in Cleveland Clinic. Best case scenario, those are probably 5 years out from the public in my mind. But if someone does have that, then they know that they are at a higher risk for cardiovascular disease, and they can manage other risk factors more proactively, like their LDL or ApoB, which is kind of becoming a little bit more mainstream than the LDL because it takes into account the atherogenic potential of triglycerides, and also things like blood pressure are very important. Iron studies, particularly for men more so, but I think women as well should get this. People will have developed iron overload and don't develop symptoms of that until usually 40s, 50s, 60s. And it's not terribly uncommon. And I think a lot of that damage that occurs later in life could be mitigated if people are being not necessarily genetically screened for predisposition to iron overload, but just looking at the iron studies themselves, like a ferritin, serum iron, and the iron binding capacities.
You're giving a lot of great information. Is there anything else you'd like to share with the audience?
Yeah, I have given a lot of information, and it may not all sound positive, but I really do like to inspire hope in my patients. So this goes back to when I was working orthopedics. It was my first job as an RN. And these patients would come in for joint replacement. It was a popular procedure at the time and still is. And it was really that mindset that these patients had that sort of captured me and inspired me, because they knew that instead of this pain getting worse and worse and worse, that they were going to be getting a little bit better each day after the surgery instead of the decline that they were seeing. And that's how I like to help my patients think about their health, regardless of if they're already in good health and they're just being proactive in screening, or if someone is in relatively poor health and they're trying to build a path back to where they need to be. I really believe that when patients come to me, they're doing the best they can with the resources that they have available. And it's just a matter of getting them the tools they need to build their way to better health.
So how can people reach you for more information?
Yeah, so patients can follow me on Instagram at James O'Hara NP, or go to my website at GilletteHealth.com. This is our private practice concierge medicine that I co-founded with Dr. Kyle Gillette. And we have a big emphasis on preventive healthcare and really individualized choices for patients, and a process of shared decision making that often gets lost whenever patients don't get to spend enough time with their providers.
Where are you located?
We're located in Kansas City.
Well, thank you so very much. I'm going to have this information at the end of this video and also in the description, so people will be able to follow up with you. And we really appreciate your time. You have a blessed day.
Yeah, thanks again for having me on.
Bye-bye.
All right, bye-bye.